Welcome, everyone. My name is Ian Colbert, and I am the Executive Director of the Canadian Public Health Association, and it's my pleasure to welcome you to this special webinar on public health system transformation to mobilize research and innovation on climate change. While we are gathering from all parts of Turtle Island, I want to acknowledge that I'm an uninvited guest on the ancestral and unceded territory of the Algonquin and Anishinaabe, and I'm very grateful for their hospitality and the example of their stewardship, their faithful stewardship of the land and our natural resources. CPHA is very pleased to co-host this event with the Public Health Physicians of Canada, and it is now my pleasure to introduce Jasmine Pawa, President of the Public Health Physicians of Canada. Jasmine, the floor is yours.
Thank you, Ian. I'd like to also extend the welcome on behalf of PHPC, Public Health Physicians of Canada, and say that tonight we're very honored to have Dr. Teresa Tam, the Chief Public Health Officer for Canada, and Dr. Christian Barron, Vice President Research Programs for Canadian Institutes for Health Research and the Interim Leader for the Institute of Population and Public Health with us to speak for the webinar. And I will at this point turn it over to Dr. Tam.
Thank you so much, Ian and Jasmine, the CPHA and the Public Health Association, CPHA and the Public Health Physicians of Canada. So great to be with so many colleagues well, for many of you, it's sort of the evening, basically. Et nous jouerons tous des rôles différents, mais complémentaires. Je vous suis reconnaissant de votre contribution unique à la santé publique au Canada. I would like to start by acknowledging that Canada is the homeland of First Nations, Inuit and Métis peoples, and that this webinar is hosted in Ottawa on the unceded traditional territory of the Algonquin and Anishinaabe people. Je viens d'arriver à l'île de la Tortue et j'en apprends encore chaque jour au sujet de notre histoire collective et des mesures concrètes pour la vérité et la réconciliation. J'aimerais prendre un moment pour vous remercier de votre travail acharné au cours des dernières années. All of you have been really, really busy, and thank you for your contribution and hard work in the many years of the pandemic, and of course, even way before that. But I hope that everyone is taking care of each other and yourselves, because as the saying goes, you can't pour from an empty cup. It's really important to check in with yourself and take a little bit of time to rest as needed. So I think Ian, you are going to show some slides on my behalf. Thank you so much. And maybe I'll just move on to the next slide. So many of you have heard me speak about my annual reports, and these are based on specific public health themes that I wanted to bring some attention to. But each of the reports also have built-in interconnections across each of them. And that includes how we strengthen public health systems and how we can achieve health equity. So tonight, I plan to share progress and key recommendations from my last two annual reports, describe the opportunities for and examples of public health action to address complex societal issues such as climate change, highlight the continued need for research and innovation to inform our public health decision-making and actions, and showcase some research opportunities related to the CPHO reports. And I'm very grateful to have my colleague, Dr. Barron from CIHR, who's going to provide a bit more detail about those research opportunities and how we can all collaborate together and sort of really build a public health system that is a learning health system. And so we'll have a bit of opportunity for questions and answers at the end. Next slide, please. So COVID-19 definitely demonstrated the public health system's strengths in being able to act quickly, boldly, and everybody rolling up their sleeves. But it also exposed some very long-standing systemic gaps which contributed to some disproportionate impacts of COVID-19 on some communities. And it revealed some of the deepened inequities that impact things like vaccine uptake, for example. So my 2020 report on a vision to inform Canada's public health system, transform Canada's public health system, was developed with the pandemic still in full swing. It was prior to Omicron, basically. We were still in the midst of the pandemic, where there was a lot of uncertainties, but public health was very much in the spotlight at the time. And I did the report to provide some level of understanding of the broad mandate and work of public health, because I felt that some of our decision makers didn't have that full breadth of understanding, and the public can't quite figure out what public health did, except what they could see in health emergency and pandemic response. I was also trying to identify public health as a critical component of the health system or the health ecosystem, and that we play a key role in the sustainability of the healthcare system itself. So I think that I also wanted to put, of course, health equity very much at the center of our collective efforts. I think since that time, and certainly as my tenure as the CPHO to date, I have seen that equity, diversity, and inclusion being more broadly incorporated and hardwired into many of our public health organizations and institutions. And CIHR also has an agency-wide strategic plan that reflects these very important considerations. And we are talking much more about the impacts of colonization and the impact on the health of First Nations, Indigenous, and Métis peoples. So there's some progress, I think, that have been made in even the last several years. The report, the 2021 report, focused on 4 areas of immediate action for public health system transformation. In the area of fostering excellence in the public health workforce, of course, there's quite a lot of attention being paid right now to the health, human resource, and the gaps by all governments. They're very seized with this. While the needs of the public health workforce are acknowledged, and the focus has very much been on the healthcare capacity itself, emergency rooms, of course, primary care, thank goodness, there's some attention being paid on that. But we need to consider how we define the public health workforce of today, so that we can more accurately capture the data on the public health human resource needs and gaps. And what would a public health workforce of the future, looking a bit more forward, look like in, for example, the digital age? Work is happening across the public health community on the renewal of the public health competencies, including amongst our academic partners, the schools of public health, and our national collaborating centers and others. So that's actually quite important work being done now. Ian and myself have been participating in the Coalition for Action for Health Workers. This is supported by Health Canada, that's bringing together many different groups that are really focused on strengthening that workforce. But we need a bit more support, really, to make sure that public health and the public health workforce is being considered in a more systematic and concerted way. In the improvement of public health toolbox, the Pan-Canadian Health Data Strategy is being developed to advance our collective need for a strong integrated data foundation that would inform our policies, programs, actions, and address health inequities. And I was, of course, very interested and I really felt optimistic when I saw the Ontario Health Data Council report on their vision for Ontario's health data ecosystem, for example. So we know there's work going on within the provinces and linked to the Pan-Canadian Health Data Strategy. I think that the public health research and knowledge synthesis needs was identified as that second bucket of improving our public health toolbox. And we will talk a bit about that tonight. But we need research actually on public health system and services research. So we need to see how we can do better and leveraging research funders to make that happen. In modernizing governance and collaboration structures, I think a lot more can be done. But in our collective response to the Mpox outbreak, for example, we did demonstrate the importance of different ways of collaboration and community involvement in decision-making and in response, which really helped us reduce the spread, stop transmission, and get vaccination programs implemented and also treatments. So involving community organizations like the Community-Based Research Center in Vancouver and many other researchers who have been working with the impacted communities throughout decades have been instrumental. So looking at what made that successful would be important for future response. And I won't speak too much about consistent funding, but certainly all of us want to make sure that in decision making and policy making in the near term that the mandate being provided for public health is clarified and that funding is being provided to support that. The next slide, please. So in my 2022 report, I wanted to look at how we can apply the vision for public health transformation to one of the most complex challenges of our time that has far-ranging health benefits, that is climate change. There have been many different approaches that have been looked at to convey a more holistic and interdisciplinary way of approaching the climate health relationship, including planetary health, Indigenous ways of knowing and knowledge, One Health, and eco-health. In my report, I briefly describe the One Health approach, which is being used in domestic and international discussions and takes an integrated and unifying approach to sustainably balance and optimize the health of humans, animals, plants, and ecosystems. But in Canada, in particular, we must recognize Indigenous worldviews preceded all of these concepts that we're talking about today, in our public health discourse. Dr. Shannon Waters provided with some key wisdoms which were integrated into that last report I published. And she provided us with wisdom on the following fronts that really resonated with me. Indigenous peoples regard land as family. So to achieve climate, what we need to do to address biodiversity loss and climate change, Mother Earth needs to be recognized as foundational to the health of all beings because the ecosystem is our health system. And we have to shift from an anthropocentric worldview and relearn that we as humans are part of a complex and interdependent web on Mother Earth. And the recognition, support, and advancement of Indigenous sovereignty is needed to protect the environment. So Indigenous sovereignty is sustainability. Next slide, please. So traditional knowledge is not just for Indigenous peoples, it is for everyone. And as settlers, newcomers, uninvited guests, we need to do our part in fostering Indigenous research leadership and Indigenous knowledge sovereignty. So my last report, even during the development of the report process, including some very purposeful approaches to recognize the strong leadership of Indigenous peoples in climate action and to recognize the disproportionate impact of climate change on First Nations, Inuit, and Métis people in Canada. Next slide, please. So I think all of us participating tonight would recognize the very wide-ranging health impact on climate change. looking at hazards, exposures, and health vulnerabilities concurrently as part of a process that's driven by local empowerment and action, I think is extremely important as we move forwards. As the climate changes further, existing health threats will intensify and new risks will emerge. And vulnerabilities such as the socioeconomic status, geographic location, can increase the potential for negative health impacts at individual, community, and population levels. And the breadth and extent of these impacts underscores that virtually all aspects of public health work will be touched by climate change. So understanding the health vulnerabilities of climate change is very important and requires careful consideration and application in the climate context. And this is where public health orientation and strengths around health equity and health promotion can be leveraged. So next slide, please. I think in my report, I try to systematically point out that the public health system and actors are already working to address the impacts of the climate crisis, but it is essential that we build on these efforts. Doing so will require greater focus on climate change considerations within public health and also strengthening the role of public health in existing climate action. In my report, I used a 5-point roadmap to detail opportunities for public health action. First of all, implementing a range of interventions to address the immediate challenges while preventing future risks. This includes both upstream and downstream approaches, and that cuts across all the essential public health functions, from health promotion to disease and injury prevention to emergency response, for example. It is very critical to have some dedicated resources to do this role. And I believe that Health Canada's Health Adapt program, which funded 10 health authorities across 5 province territories to develop some projects that address climate-driven health risk, is one example of how to provide at least some resources to kickstart some of these actions. And there are some very nice videos of the project leads describing what they're doing under the Health Adapt program funded projects. So in the secondly, public health can support applying an equity lens to climate change, including prioritizing action for communities facing disproportionate risks and enabling community participation and co-development. And this also includes environmental justice, in which no population suffers unjust and disproportionate environmental harm. And I was very pleased to see that Environment and Climate Change Canada has a director of Indigenous Science Division, Dr. Ballard at the University of Manitoba. And that's a really important step forwards, which leads to my comment on the third area of action, where we must address evidence gap by building knowledge on climate health connections through research, surveillance, and Indigenous knowledge. And you'll hear a little bit more about that tonight. But we've also got to share best practices, because as I was on the ground in Vancouver just recently, participating in a roundtable hosted by the BC CDC and the Public Health Agency as a knowledge exchange forum, it's very obvious that there's some great examples on the ground in British Columbia, where there's been work with communities on climate action. And one particular study that really struck me was the Indigenous-led Tea Creek Food Sovereignty Initiative, which was funded through agriculture skills and training, that show the immense co-benefits that you can have on connection to land, on Indigenous food sovereignty, on mental and physical health, job creation, climate adaptation, stewardship of soil. That was a great project. And I think there are many more examples of intersectoral climate action projects across the country that needs to be amplified, and we need more support for knowledge translation. Fourthly, we need to look at interjurisdictional and sectoral collaboration, and that this is, one of our forte really, is to work across sectors and also to enable other sectors and ministries to collaborate together for transformative public health action that has intersectoral co-benefits, including health co-benefits. And finally, there are key areas where public health can demonstrate system-level leadership while advocating for climate change. Some of these will need to, these approaches need to prioritize dedicated resources to inform coordinated action. And I think Health Adapt does provide a little bit of resource. There are some local health units that are, for example, co-locating staff in municipal planning to build healthier and sustainable environments. I think all of us together with our healthcare system can shift to low carbon systems and strengthening the foundations of the public health system itself. I think that public health can frame climate change in very tangible ways, so that is very relatable to the general public, and that our expertise in health promotion in connection behavioral sciences can be leveraged to shift people's adaptive behaviors. And so the next slide, which is my last slide, I'm really happy that my last 2 annual reports have been accompanied by a research opportunities document. And these documents are targeted towards the research community, research funding organizations, and are being used to inform evidence generation and scientific priorities that can support mobilizing the report recommendations. And it's great to have Dr. Barron here today to talk about the CIHR Catalyst grants, but also maybe other funding opportunities so that all of you can be aware of them and maybe submit applications. The road ahead in strengthening public health is not easy. It's important to position public health, as I said, to be part of the solution to the challenges in our healthcare and health ecosystem. And I am actually quite hopeful. We need to maintain hope and for, mental health and other reasons as well. But I think that the importance of health and well-being is now reflected in Canada's first national adaptation strategy. So that's great news. There's attention paid to the health aspects of climate change in the UN Conference of the Parties, COP27, and indeed prior to that. And I think there will be more attention paid to health impacts and adaptation in the next COP meeting. There is a continued need for research and innovation, and there's an ongoing opportunity under Climate Science 2050, which we can chat a little bit about. But what I want to sort of end my presentation today, and indeed the core message in my report, is that action brings hope, and action at individual, at our system levels, and collective action is how we really move forwards. So I look forward to hearing your ideas, and I'm happy to answer questions after our CIHR presentation.
Thank you, Dr. Tam, for that part of the presentation. And while we're just switching the slide decks, I'd like to invite Dr. Barron to turn on his camera and join us.
Yeah, I will mount. Thanks very much. I will mount my own deck, I think. Unless technology doesn't work, but I think it shouldn't be too difficult. Voila, I think that works. So my name is Christian Barron, and I'm the Vice President Research Programs at the Canadian Institute of Health Research. As mentioned already, I'm also wearing the head of interim scientific director or kind of advisor, administrative, and the person who provides administrative oversight for Institute of Public and Population Health at the moment, and to recruit a new scientific director. And I'm looking forward to talk about some of our shared work. I'm here in New Brunswick I'm typically located in Ottawa, but today I'm speaking to you from New Brunswick, which is located on the traditional territory of the Wollastetuyok and the Mala peoples, who have lived here since time immemorial. Reflections, I think, which are very important for all of us as we work towards a reconciliation as a society to overcome the long-standing damages of, and intergenerational trauma caused by colonisation. Je suis ici aussi pour présenter en anglais, mais comme Dr. Tam, je suis tout à fait en mesure de répondre à des questions dans la deuxième langue officielle en français, si jamais ça vous intéresse à un moment donné cette présentation. Merci. Alors, I start out by talking about CHR, Canadian Institute of Health Research. Most of you will be familiar with our organization. We have an annual budget of about $1.3 billion, which is rolled out in part by an open competition. I will talk much about budget today, but it's rolled out in a very significant fashion by our 13 research institutes. 13 research institutes which cover the full spectrum of health research in the country. And of course, the Institute of Public and Population Health is as the core of what I'll be talking about today in the context of this presentation. So when you look at IPPH, as we know, we talk always in acronyms in the government of Canada, as you know well. IPPH is an institute which has been very ambitious in recent years, has published relatively recently a strategic plan which has 4 key goals. Healthy Cities is an initiative, is a major initiative which may involve many of you, focused on implementation science in cities where most Canadians, actually most parts of the global population live. It's well on its way. Initiatives that are more at the developmental stage are in equity science, global public health, and public health systems. Public health system is something I will talk a bit more today, since it's linked to Dr. Tam's presentation and to funding opportunities from the past and those which will be upcoming. When you look at our overall objective of our public health system priority area, we want to strengthen the field of public health systems and services research in Canada in general, to enable the systems transformations and to improve the health of all Canadians. There's three key objectives: generate evidence on key public health system research priorities. We also want to enable a learning public health system that can undertake context-specific systems research and reforms. The learning health systems approach, also called LHS at CHR, certainly not only at CHR, I think is more and more at the core of what we want to do for the future, that we have a system which, there's room for improvement. I think we all agree, and we should learn from the current situation and iteratively improve towards a system that continuously gets improved and better serves Canadian. Certainly, we want to strengthen the alignment with public health research and community practice and policy need. The time where research was done, in kind of ivory towers, detached from communities. I think that's long over, not only at CHR, but certainly also at CHR. Community-based research and their implications are extremely important for us. It's part of our DNA and what we do and what we value and what we fund on the behalf of the government and of all Canadians. Of course, this is a big job, and we cannot do this alone. Partnerships are critical for work we as a funder do. Partnerships with researchers, partner with the communities, with knowledge users, with participants, patients. And FAC is, certainly one of our prime partners. We work so closely. Dr. Tam has already mentioned this in some instances, but we work very so closely with FAC. We even exchange our executives on a regular fashion. So, as many of you may know Zara Vivek, who is now Chief Science Officer at FAC. Stephen Hoffman also, and the reason why I'm actually sitting here is because Stephen Hoffman has had fantastic opportunities at FAC, and we are so excited that we will continue even more, work even more closely with us. So for us, working with FAC, PHAC is really key for our work. And we will talk a bit about funding opportunities, but what we do is, we are often in daily, weekly, certainly in weekly or sometimes daily contact on our priorities linked to our respective work for the government of Canada. already mentioned one of the mechanisms. There's not only one mechanism, but one of the mechanisms which has been used are the catalyst grant opportunities, which are linked to the reports of the Chief Public Health Officer. And I couldn't talk about this better than Dr. Tam has already. We as a mandate, as a research funder, we will support high qualified research, which is aligned with priorities by Dr. Tam's reports. Kind of extramural research, of course, which is done in complementarity with the intramural research done by government scientists. We want to strengthen links with knowledge users, decision makers, including communities, and build capacity aligned with these priorities. There have been investments done in the last 2021 report to fund about 20 applications. Now we launched early in December the Catalyst Grant funding opportunity for linked to the 2022 report linked on climate change research, which will offer at least $1.6 million for funding for up to 13 applications. And maybe linked to this, we talk a lot about climate change and research activities in climate change at CHR right now. Which are, the National Adaptation Strategy was mentioned already, climate science for 2050. We as part of members of the Government of Canada, we are really very engaged in this topic. And after I'm done here, I will actually place a funding opportunity into the chat, which was just published by the New Frontiers and Research Fund, which is quite significant. And maybe this will be interesting for some of you. Just as an information, here examples of funded research projects are displayed here on the screen, which are from across the country. Research activities funded, linked on core competence for public health professionals to transform the health practice, again, strengthen capacity for public health leadership and decision making, and virtual primary care systems. So, we fund the full spectrum of what is considered pertinent and important, and we will continue to do so. And I strongly hope, of course, we cannot underwrite check right now, but I strongly hope that we continue the collaboration we had with FARC and with other partners, and we're building on that to work also with other partners in the Government of Canada to work together in the future. Avec ça, je pense que je suis à la fin de ma présentation. I think I'm at the end. Thank you very much. Merci beaucoup de votre attention. Voilà. Thank you.
Thank you very much, Dr. Barron. So as we move into the Q&A, I think this is at a point where I'll share a few thoughts on my end, pose the first question. Very much encourage everyone to use the Q&A module to put questions and thoughts, things you'd like to share and ask. I want to thank both of our presenters for the presentation. Heard many things, including the value of reflection on our own assumptions, lenses, bias, the perspective we're bringing, and the importance of valuing expert knowledge and valuing worldview, a range of worldviews, particularly Indigenous in Canada. And as we think about what we know of the history, also connecting that to our actions day to day. We heard thoughts about dedicated funding resource for this work, how some of the research pieces connect in, both what's been done in the past and what comes in the future, and about the health workforce, both public health and healthcare feeling burnt out with shortages, exhaustion. Very much support the comments around defining the public health workforce, both what it looks like today and what we think might look like in the future. And also hoping for work in this area and research in this area that understands well and supports public health practice and service delivery. And I think has been mentioned a few times, figuring out the partnerships for us to be able to do that. In addition to all that, I know that many who are choosing to spend an evening listening to this webinar, and the reason we're doing it is that there's agreement that we need actions around climate change and increased actions or different actions to what we're doing now. So the question I'd like to pose to the two panelists is, there's many potential interventions outlined in the report or approaches, things to consider. And I'm wondering how in the context of some of these workforce challenges or exhaustion, where to start if there's strategies you can think of that would help in that context, and what might be 2 to 3 things you might think about prioritizing or encourage people to look as a place to start. So maybe I'll start with Dr. Tan and see if you'd be willing to share any thoughts on that.
Yes, I'm certainly concerned that, while the policymakers and the general public are very focused on the gaps right now in the healthcare system, they've almost, sometimes I feel like they've forgotten that we've been through this pandemic for 3 years, and that we are dealing with a very exhausted workforce. And so I know that when Ian and myself attended the coalition on the health workforce, so there were many different ideas actually suggested to support mental health, burnout, sick leave. There's lots of other aspects of supporting the workforce, but also, of course, training and attracting and training students to join the workforce itself. So there were contributions from the academic sector on how to, best do some of that. I think the unions representing the workers were also, engaged. And there were some examples of how some public health organizations are trying to give the staff a break at the same time as trying to respond to multitudes of things. So I think the bottom line is that this probably should be a way of capturing some of that information and sharing this experience using different platforms, including webinars like this, perhaps, or other approaches so that people can learn from each other. I think by sheer will and passion about supporting our communities, people are kind of hanging on. But a lot can be done. And recruitment on, say, public health nurses wasn't really discussed specifically, but recruitment of nurses in general have been discussed, including, of course, international graduates, immigrants who are already here in the country. The other thing is looking at surge capacities, and we mustn't lose some of the gains during the pandemic when we have been able to leverage others. And at the federal level, we leverage the Red Cross and other programs. And how do we solidify that as part of our pandemic preparedness? So that as we're running these marathons, we know where the surge capacities come from. And it would be well worth documenting some of these and make sure that the arrangements are there to sustain the response and sustain the workforce.
Thanks, and maybe I'll provide the same opportunity for comment on your end, Dr. Barron.
Yeah, thank you for this opportunity. I mean, there's things research can do and research cannot do. I mean, research provides evidence, and certainly research we've been funding together with our colleagues, have looked at, healthcare models, more advanced models of managing the healthcare workforce, which, are significantly different from the traditional way of managing healthcare workforce and the staff. When I say more traditional, maybe doctors working alone from nurses and other healthcare professionals, there's other models out there. But then there's things, of course, we as public servants and research funders cannot influence. These are decision makers based on the professional orders, unions, and politicians. But I think I can share that, we are CHR at FAC and Health Canada. We're not only research funders, and so CHR is a primary research funder, but we are more than that. We provide advice in collaboration with our colleagues in the health portfolio, which we certainly hope, based on what we know, we've learned about research, but that we can also influence decisions which will be made, which could be everybody reads the news, right? And what could be emerging here in Canada in the not so far future, and certainly our colleagues and us, we've been at the table providing the evidence that hopefully decision makers will decide will ultimately use to improve the healthcare system.
Thank you. And at this point, I'll turn it back to Ian to moderate the rest of the questions.
Thanks so much, Jasmine. So we've got some great questions coming in from our participants. First one, I apologize. I don't know how to pronounce your first name. I'm going to say Senwen Pope. I'm probably very wrong, but she wrote, regarding the public health workforce, the U.S. has the Public Health Workforce Interest Needs Survey to help understand workforce needs issues, but Canada is missing this kind of data. Is there any consideration preparing a similar survey in Canada? And perhaps I'll give that to Dr. Tam.
Yes, I'm not sure if Dr. Corey Needorf is on the line, but I know that he and I have discussed this a fair bit, and the Urban Public Health Network has done some foundational work already in this area and leveraging on the work from the United States. So this is something that I know that he's quite passionate about, along with the network. And so I guess my answer is yes, this is undergoing discussion. And we're not starting from scratch. There's been some thoughts provided on this. There was a publication that Dr. Neudorf was also involved in on defining that public health unit. And in order to actually perform research, you actually need to, I'm not sure whether I call it a data definitions or standards, but measurements of those units. And the other thing are measurements of public health intervention or public health intervention classification. Some of those foundational work I think is important, but unfortunately, it's not traditionally the kind of work that is funded through, say, CIHR. So we need to kind of look at other mechanisms to support that.
And certainly, if I may, it's a conversation that the Coalition for Health Workers, Action for Health Workers, is certainly talking about. It's not unique to public health. But I do think other professions have a little bit better grasp of their workforce size than the public health, because it's the context in which we do our work. It's not necessarily our professional hat that we wear on a daily basis. So yeah, it's certainly being discussed at a lot of different tables these days. So our next question is from Tim Takaro. He says, thank you for speaking to us, Dr. Tam. You mentioned early in the presentation that adequate funding for meeting the challenges of planetary health and protecting Mother Earth will require This will require transdisciplinary research that develops and tests interventions that build resilience and strengthens communities. Historically, environmental and occupational health, eco-health, One Health, planetary health have been woefully underfunded by CIHR. Because of the transdisciplinary nature of the work, funding commitments should be across several ministries, including health, as New Frontiers Resource Fund is partially doing. What efforts are underway to make the Treasury requests, I'm thinking maybe Treasury Board requests for such multi-ministry funding? How can those of us in public health practice and the Academy best assist in this? I don't know which one of you would like to take a first stab at that.
I was going to suggest Christian to start.
Yeah, that's okay. I would say point well taken, but watch us. I mean, CHR is not what we traditionally used to, and I'm not here to talk about our strategic plan, but when you look at our details, this is where we're going to. And the concept you have, you have a very good comment. The context you made is well taken. There's things under development which will surprise many. Certainly, CHR is not is still perceived as funding primarily biomedical research, and which we still do too, if you look at the dollar values. But our research portfolio is quite diversified, and will continue to be more diversified in future. Exactly, using the notions you mentioned. When people ask me about how to make sure that decision makers are being influenced, our short answer is typically talk to a member of parliament. But seriously, it is we are public servants. We roll out monies which they decide to allocate us based on everything they hear, and that's their right. That's what they're elected for. It is really by talking to decision makers. And I might suggest my impression is that the younger generation is even better. This is being heard, and is being heard even more than people who are more advanced in their academic careers, because in the end, it's their planet, it's their future. I mean, of course, it's also our future, but the next generation has reason to be particularly preoccupied by the effects of climate change and by everything which has happened in public health. And in the end, maybe I don't want to say we cannot do anything, but I can tell we do more than is known. But there's things we can do in government. But those who are living in our population, they have leverage. They can do things by directly influencing decision makers, and they listen to those who elect them. I can be assured.
Teresa, I'll just add that one of my recommendations is ensure public health is at the table for intersectoral approaches. And in the federal context, our lead department is Environment and Climate Change Canada. So making sure that we're at that table, I'm trying to, do my own linkages. But there is Climate Science 2050. From the Public Health Agency, our Chief Science Officer, Dr. Sarah Viebeck, is linked into that. So her role would be to advocate for these types of multidisciplinary research approaches. And the other thing that I certainly been thinking of is, of course, CIHR is not the only funding agency or research funding agency I'll be approaching. The Tri-Council and other research funding organizations will be on my sort of list of engagements.
Excellent. Thank you both for those responses, and we'll look forward, hopefully, to some news from CIHR on this topic. So Heather Willette writes, what are your thoughts on rolling public health nursing into the primary care model, or as the next person responds, the primary health care model? In my area, it has resulted in a focus on the visible and countable tasks that nurses do, for example, vaccination, and a loss of things like community development work.
Yes, so I might not be the most informed person in this area, but I do know that using a population health approach in primary care is an area of active pursuit, if you like. It's a good model. And we've heard of, also social pediatrics or other approaches to supporting patients within the context of their community. And there are leaders in this area. So I do think that capitalizing on that work will be very important. And maybe then public health nurses, the nursing profession in this area, can leverage their expertise from a population and community health perspective into those primary care teams. I don't know if that makes sense, Ian. There are definitely, even from hospital acute care, people are trying to take a more population-based approach, knowing where patients come from and their experiences, what happened to them, and is part of that. And the solutions to health care or health medical conditions is often prescribing something that's non-medication, non-pharmaceutical. I think those kind of ideas are taking hold, And it should be informed by evidence as well, that if they work, that kind of approach could be extremely beneficial and at a relatively low cost.
Exactly. Thank you for that. So the next question is from Paul Hasselbach, who writes, climate change is a slow-moving public health emergency. We are only a few decades since it was first acknowledged as a potential concern for Canadians. Is it possible to formally declare the situation as urgent and pressing, as well as unlikely to be reversed?
Well, I think one question that's always been posed to me was, well, why now? You know, why write a report on public health action and climate change? Seriously, we have no choice. I think that's the thing. We have to act because the health impacts of climate change and climate change impacts on all living things and on our land is a very real thing. It's actually now moving faster. Maybe it was slow moving before, but I think in my sort of opening presentation, I was saying that through the health impacts, we can make the impact of climate change real to individuals. Whereas, you know, ozone layers and levels of greenhouse gases might seem a little obtuse. Knowing that there are health-related, heat-related injuries that is happening, flood, and all sorts of food impacts on the safety of our food systems and food security has now made things very real for individual communities. So in some cases, you are actually in an emergency, of course, more often than not. So that will be declared at the local level often. But I think more broadly speaking, is that there's some sense of urgency now that I haven't quite seen before, possibly because we're now getting a bit more desperate, and that the health and well-being aspect are now being recognized more acutely. So just like AMR and other things, it's very difficult, let's say, for the World Health Organization to say this is a public health emergency with an national concern. They tend to be more discrete events, although, you know, of course, COVID is very long and drawn out. At some point, the disaster, you know, crisis phase should end, and we get into a more sort of predictable and sustained approach. For climate change, I don't think that's the case. So that is not a discrete, you know, international event. So we need to take a different approach. But I do think that unlikely to be reversed is something that one has to challenge. It may take a long time for some things to be reversed, but we mustn't lose hope. We can regenerate soil. We can actually improve air quality fairly rapidly if we did certain actions. So I think agency, individually, as a community level and as health system level, is really important. Otherwise, I think, as I said, mental health will be severely impacted if we just talk about the issue without giving people solutions and tools.
Excellent. And if without sound like a total sycophant, I would say your 2022 report is that clarion call to both the public health community and the broader public. It is the one tool that the Chief Public Health Officer of Canada has to communicate directly with Canadians. And you've highlighted this point very clearly. So I think that there is no other tool available in the federal government to declare a public health emergency. So this is as close as we get. So thank you for focusing your report on what is the existential threat to us all. So thank you. Moving on to David Poon. How have you found navigating different priorities than other government agencies when attempting to enact successful policy change? That's a huge question, but how do you negotiate with other players around government if their priorities are not the same as those of you and the agency?
Yes, I was trying to figure out how to interpret the question, and I mentioned the idea of co-benefits, which is really important. When I reach over to other government departments, is, first of all, partly because I know they have resources often that we can perhaps tap into, but that it is supportive of their mandate as well as reaping health co-benefits. So some of you might remember Smart Cities as a federal initiative where, some of the winners of those proposals have, it was like in the millions of dollars, right? So with that in mind, I certainly reached over to Infrastructure Canada, who's the lead on smart cities, as I was doing my 2017 report on the healthy built environment, and try and make sure that I'm supportive of what they're doing, but to say that, well, smart cities are healthy cities, smart cities are sustainable cities. And so it's at the beginning, they may not have the health intersectionality with what they're doing was not necessarily obvious, but then it became really obvious when the applications came in, I think, and over half of them has something to do with health of the communities. And CIHR also was engaged together with us to make sure that the ministries like infrastructure understand a bit more about the importance of population health in their programming. But also, I was really there to advocate for equity. And we are also on the climate change side, making sure that we don't get into maladaptation through an inadequate consideration for equity.
Great, thank you so much. So question here, which Indigenous communities are already involved in leading the research to support and increase research along with Public Health Agency as well as CIHR? I don't know if either of you would like to respond to that.
I can take a stab at that. Certainly, one of the 13 institutes, CHR, of CHR is the Institute for Indigenous Peoples' Health, IIPH, which is Indigenous-led and funds Indigenous health research. It would be difficult to give a detailed number here, but CHR has committed many years ago to allocate 4.6%, at least 4.6% of our budget to Indigenous health research. And a lot of this research is conducted and led by Indigenous researchers from various, groups, First Nations, Métis, and Inuit. And it would be more detailed information. We would have to have an offline conversation. But for us, it's very important that research does in collaboration also with non-Indigenous researchers, but a lot of this research is led and inspired by Indigenous needs and research and absolutely. Any Indigenous health research has to be distinction-based, culturally safe, and respect the needs and the needs and requirements of our Indigenous colleagues and populations. So I'm not sure for FAC, but for us, this is when you look at our strategic plan, there's 5 priorities. And one of the 5, only 5, not 25, there's 5. And one of the 5 is improving the wellness and auto-determination of Indigenous peoples in Canada.
Excellent. Well, we are approaching the top of the hour, so it is my opportunity to say thank you very much to Dr. Barron, Dr. Tam for being with us for this very informative webinar. Thanks to our participants and all the great questions. I'll just remind everyone that this webinar was recorded, and it, along with the presentations, will be made available on CPHA's YouTube channel as soon as possible. And everyone who registered for tonight's session, or this afternoon session, depending where you are, will receive notification when that recording becomes available. So I want to say thanks again to Dr. Jasmine Pawa as well from the Public Health Physicians of Canada for co-hosting this special webinar with the Canadian Public Health Association. Have a great day.